Great responses. It is truly an honor to have you here. So with that, we conclude our Q&A segment, and we will be moving right along. All right, so next up, we have the student presentations. First up is Dr. Durga Matlapudi presenting on antiphospholipid syndrome.
Hello everyone, my name is Durga Matlapudi. I'm a medical student from India planning to apply for residency next year. Today, in recognition of World Thrombosis Day, I would like to talk about antiphospholipid syndrome. This disorder is a prothrombotic ailment characterized by the presence of an antiphospholipid antibody in the patient's serum and a significant history of recurrent arterial and venous thromboses or pregnancy complications like recurrent miscarriages, premature birth, and unexplained fetal death. Antiphospholipid syndrome can be classified as primary or secondary. Secondary essentially means it occurs in individuals already with another autoimmune disease. This most commonly being systemic lupus erythematosus, or SLE. Primary means the disorder has no other features that suggest that there is another disease process taking place. 50% of the patients with antiphospholipid syndrome have the primary form. The pathophysiologic processes that occur in this disease are not well defined, but animal studies have elucidated that it is mostly due to antiphospholipid antibodies, like beta-2 glycoprotein 1 antibodies. Rodents injected with these antibodies were found to have developed thromboses. The antibody, as the name suggests, targets the ubiquitous beta-2 glycoprotein 1. This protein is normally present in the serum but binds readily to the anionic phospholipids on endothelial cells, monocytes, platelets, and trophoblasts. Due to this propensity, the antibody targets the protein and activates those cells, creating a prothrombotic state. Beta-2 glycoprotein 1 is also known to have procoagulant effects on protein C, annexin 5, serum proteases, toll-like receptors, and tissue factor. Other factors that increase the likelihood of thrombosis is increased complement activation and inhibition of fibrinolytic processes by the antiphospholipid antibodies. Despite their clear association with the disease, their sole presence is not enough to induce it. Antiphospholipid antibodies are thought to be present in 5 to 15% of normal individuals. Due to this, a second hit is thought to be necessary, which may be evoked by conditions like infections, hypertension, smoking, prolonged immobilization, pregnancy, hormone replacement therapy, and nephrotic syndrome. The clinical features of this syndrome primarily depends upon the subtype. Secondary antiphospholipid syndrome is associated with a higher incidence of arthritis, heart valve disease, thrombocytopenia, leukopenia, and livedo reticularis, which is a nut-like pattern on the skin caused by swollen blood vessels. However, both subtypes have an equal predilection for early atherosclerosis and other cardiac risk factors. Other significant clinical manifestations include, but are not limited to, deep vein thrombosis, stroke, fetal loss, pulmonary embolism, and transient ischemic attacks. An interesting point to add to this is that fetal loss is not due to thrombosis, but due to antibody-mediated dysfunction of the trophoblasts during placentation. Stroke may be due to in situ thrombosis or embolization of valvular vegetations in the heart. A separate syndrome called Sneddon syndrome is characterized by the presence of livedo reticularis in a stroke patient. Half of the patients with this syndrome are also found to have the antiphospholipid antibody. Treatment for antiphospholipid syndrome depends largely on the clinical presentation. Asymptomatic patients who are known to have the syndrome, for example, those that are known to have the antibodies with a history of field demise, do not require preventative measures, especially if they have no history of a thromboembolic event. Treatment of acute thromboembolic events consists of heparin with warfarin. This is especially challenging because heparin activity cannot be actively monitored in the body due to paradoxical elevation of PTT due to the patient's antibodies interfering with the test phospholipids. Secondary thrombosis prevention consists of warfarin to achieve an INR between 2 and 3. This regimen should be continued indefinitely to ensure patients are at decreased risk of having exacerbations. It has been a pleasure making this short video. I hope I was able to educate everyone on this thrombotic disease. I want to thank Dr. Kottapalli for this opportunity, and thank you for watching this video. Hello, everyone.
Thank you, Dr. Durga. Next up, we have Sruti Akula presenting on the 1-carbon pathway and its connection to thrombosis.
Hi, my name is Sruti Akula, and today I'll be talking about the 1-carbon pathway and how it's linked to thrombosis. So what is the 1-carbon pathway? The 1-carbon pathway interlinks folate and methionine pathways to provide a 1-carbon or methyl group for the synthesis of various groups such as DNA, amino acids, etc., etc. So how does this relate to thrombosis? Increased homocysteine levels lead to increased endothelial damage, which increases the risk of thrombosis. Conditions that increase homocysteine levels include CBS deficiency, a decreased affinity of cystathionine for pyridoxal phosphate, methionine synthase deficiency, and a methyl tetrahydrofolate reductase deficiency. All of these conditions are autosomal recessive conditions. So delving a little bit deeper into CBS deficiencies, like we said earlier, CBS deficiencies present with increased homocysteine levels, which lead to endothelial damage, which increases the risk of thrombosis. These individuals often present with homocystinuria, vessel thrombosis, intellectual disabilities, lens dislocation, and long, slender fingers. Treatment for these individuals involves decreasing the load on these pathways, and that can be done by decreasing methionine in the diet, increasing cysteine in the diet, and providing B6, B12, and folate in the diet. Once again, my name is Sruti Akula, and if you guys have any questions, my email can be found below. Thank you. Hi.
Thank you, Shruti. That was a great presentation. Now we have Shri Moturu presenting a Kawasaki disease case report.
Hi everybody, I'm Shri Moturu. I'm a third-year medical student at Nova Southeastern University. I'm here to present on World Thrombosis Day Kawasaki's disease, and this is a unique pediatric case, so let's get started. The case presentation involves a 4-year-old boy that comes to the emergency room with his parents for evaluation of a persistent fever that has lasted the past 7 days. His general appearance is irritable and he's inconsolably crying. The parents report that the patient has had 3 episodes of vomiting. His past medical history is insignificant, and his family history shows that his mom has osteoarthritis, hypertension, and type 2 diabetes. His father has hypertension. His social history involves that he has traveled to China last year to visit his extended family. Because this is a pediatric case, we like to ask about vaccinations, and this patient is up to date on all recommended vaccinations for his age, but he is not taking any medications currently. His vitals show that he has a high fever, he's tachycardic and tachypneic, but his blood pressure is stable. His physical exam shows that he has a diffuse polymorphous erythematous rash. He has erythema of the palms and soles. He has bilateral conjunctival injection without exudate, and he has an enlarged erythematous tongue, also known as strawberry tongue. He has non-pitting edema on all extremities, and he has cervical lymphadenopathy. His labs, his CBC shows mild anemia, left shift, and elevated white blood cell count. His echocardiogram shows an enlarged heart with coronary artery aneurysms of the right coronary artery and left anterior descending, and he has thrombosis of the coronary arteries, which is why this is a significant case for World Thrombosis Day. The diagnosis of this patient is Kawasaki's disease. It's an acute vasculitis of the medium-sized arteries. It's commonly seen in Asian infants and young children. As you recall, this patient did travel to China, so that should tell you the demographic that we're dealing with. And the hallmark symptoms is crash and burn. So as I mentioned before, conjunctival eyes, a rash, cervical adenopathy, edema of the extremities, erythema of the hands and feet, and a fever that lasts about 5 days or more. The treatment for this patient is aspirin and IVIG. You give IV fluids, and you admit this patient to the pediatric intensive care unit for further observation because of the cardiac complications associated with Kawasaki's disease. The reason I picked this case for World Thrombosis Day are that the two most common causes of death in patients diagnosed with Kawasaki's disease are myocardial infarction and coronary artery thrombosis. Preceding death, these patients will present with weakened vessel walls due to inflammation. The weakened walls are likely to develop aneurysms and are prone to rupturing and also developing further thromboses. The thrombosis will decrease the blood flow and oxygen supply to the myocardium. This then induces a myocardial infarction, ultimately causing death in these cases. And this is why it's so important to have this as a differential diagnosis for children that present with the symptoms, the hallmark symptoms of Kawasaki's, and are also of that Asian demographic. And it's an unlikely case to see hypercoagulable states in children. You typically see them in diabetics, hypertensive patients, chronic smokers. And so this is a unique case of a thrombosis in pediatric situations, and I thought it was important to shed some light on it today. Thank you for this opportunity. I know that there are some medical students and pre-medical students also presenting today. So if you guys have any questions, my email is written here, so please feel free to reach out. And I'm so grateful and proud of being a healthcare professional, especially today during our global pandemic. Thank you so much for this opportunity.
Thank you, Shri. That was very interesting. Next, we have Sathvika Akula presenting on cancer and thrombosis.
Hello everyone, my name is Sathvika Akula and I'm a sophomore at the Academy of Science and Technology. Today I'll be talking about thrombosis and how cancer factors into it. What is deep vein thrombosis? DVT is when a blood clot develops in your deep veins, usually in your legs. It's extremely deadly due to the possibility of this clot loosening from your leg and moving up to your lung, which is a pulmonary embolism. A pulmonary embolism blocks the normal blood flow in your body and causes severe issues and possibly even sudden death. Despite being extremely common, the awareness of this condition is not proportional whatsoever and is severely lacking. You can see in the top right corner, a study showed that only 27% of Americans are aware of DVT. Are you at risk? If you have checked any of the boxes below, you should consult your doctors because of the heightened chance of contracting DVT. Specifically, I'll be talking about cancer. Cancer increases your risk of developing these dangerous blood clots due to the combination of genetic changes that cause cancer and chemotherapy drugs, which both lead to the activation of clotting factors. The three main factors that lead to DVT of cancer is the type of cancer, the method of treatment, and the level of physical activity that you partake in. The method of treatment that you should be most concerned about is chemotherapy, because in addition to killing cancer cells, chemotherapy also releases substances that promote clotting into your bloodstream. This visual provides a more detailed view of cancer and thrombosis. A cancer cell contains inflammatory cytokines, pro-angiogenic factors, in addition to superficial adhesion molecules, all of which trigger procoagulant activities, or in other words, blood clotting, which leads to DVT if done in a deep vein. So what can you do to ensure that this preventable condition doesn't take the lives of more than the 100,000 it takes per year in the US alone? You can share with your family and friends, and don't remain a bystander. This visual allows you to get a more in-depth understanding of what DVT is, its symptoms, its preventions, etc. So I want to end it off here with use your voice. Share with your loved ones, because someone in the future who would just pass off a swelling in their legs or soreness as nothing can have the knowledge to go to their doctor with this due to the possibility of it being DVT and taking their lives. Thank you for listening.
That was a great presentation by Sathvika. Thank you to all the student presenters for creating those informative clips. We will now move on to the next segment of the webinar, in which the delegates will be presenting on various topics. The structure of this section will be as follows. Each delegate will be given 6 minutes to speak on their topic, and at the 5-minute mark, there will be a buzzer noise to let the delegate know that there is 1 minute left. The buzzer will sound like this. One moment, I think the sound is loading. Okay, I think we can move on, but at the 5-minute mark, there will be a noise to alert you that there's 1 minute left. And so we request the delegates to stop sharing their screen after their presentation is complete, so then we're able to introduce the next speaker who will then be able to share their presentation.
Starting off will be Dr. Kiran Kumar Makanini, who is a consultant vascular surgeon. He served as an assistant in surgery and has presented many scientific papers across India. He will be presenting on the prevalence and preventative measures of venous thromboembolism among COVID